Thank you. I'm sorry for bothering you again with my presence here. To answer your question, doctor, we don't have 5.5 in our center. So we would like to have 5.5, but we have only ECMO. So there is no other option. We have to continue with that kind of support. So I'll go briefly again on the ECMO plus Impella. What is it? There is basically two conditions where we need to go on two devices. One condition is you start with Impella. Impella is not sufficient. You can have RV failure. You can have suction alarm. Impella support is not enough, and so you have to go over with another device, which is usually ECMO. The other condition is your patient is on ECMO, but you need to unload the LV. There are several indicators for LV unloading needs. I will not go through all of these because it's outside my scope of my presentation. So what's important to understand is when you have to upgrade your device in the cath lab. I'm referring now to this patient. So this is our protocol, which is not our own protocol. This is a protocol developed in Houston by the Tom Ford Institute. Basically, it's based on right heart catheterization. I don't trust the Impella Smart Assist console. We use right heart catheterization as one guns in every single Impella we do. This is important because CPO and PAPI, which you already listened about, is the two most important indicator. I don't want a derived measure. I want the right real measure. So that's why we use right heart catheterization in all our cases. So what happened once we finish our procedure under Impella? We have to remeasure our CPO and PAPI and see how it's going. If this patient is stable, is off of pressure, or maybe minimal amount of pressure, CPO is above 0.6, we can send this patient to the ICU on support. But if patient is not supported well, CPO is still lower than 0.6, patient is still struggling, we have to upgrade immediately the support. Every hour, you saw before, every hour you lose, increase mortality of 10%, and then you will reach a moment where patient is too late, whatever you do. So we have to really avoid multi-organ failure. So this is our protocol. And this is indeed what happened when you do the Impella strategy and your patient is on ECMO and you want to vent this patient. So you already saw the pressure curve, so I will go very fast, just showing here that this is a case of patient which is on ECMO, and basically the wedge pressure is very high, above 40. You start Impella, you see that the wedge pressure goes down, and patient, of course, have better lung function. So again, the Impella strategy can help you removing ECMO faster. Because you can go down with your ECMO support, remove this high pressure you put on the arterial circulation, and patient can stabilize on Impella flow. So you go down with ECMO, you increase your Impella flow, and finally you can remove the ECMO device. Let's go fast to my case. This is a 46-year-old gentleman presented in another center, chest pain since 5 hours, hypertension, diabetes, anterior ST elevation, plus inferior ST elevation, right bundle branch block, and first degree AV block at presentation. Blood pressure was 100/60, heart rate 110, so he's already in shock B. We don't have lactate at presenting ED. He was shifted to our cath lab once arrival. Blood pressure was lower. He was in complete AV block. pH, that's something we do, ABG at arrival for every single STEMI cases, was 7.1. Lactate 12. Saturation 63, already on oxygen. So this is a Sky class presentation is C. So this condition in our protocol say you have to go on protected PCI directly. So this is first injection. You see the temporary pacemaker already on. There is basically dual artery STEMI. So there is occlusion, thrombotic occlusion of the RCA and proximal LAD thrombotic occlusion. So Impella on. First of all, angiography. We have time to go on angiography. We have to support this patient, as I told you before. Site is okay, the artery is okay, Impella is on, PCI done on LAD, PCI done on the RCA, while supported by Impella. But at the end of the procedure, CPO is still low, 0.4, PAPI was 0.8, so there is already RV failure here. Impella alone will not be available to support this guide. You will have a lot of suction alarm, you will have hemolysis, so this patient need more support. So ECMO insertion, so here distal perfusion done, of course, in advance. ECMO insertion, this is the chest X-ray done at presentation in the ICU. Here comes the challenge, of course, in ICU. You see, this is our pulmonary artery catheters, always on when we have the Impella on board. Really, this give you the difference about what to do. By the way, first ejection fraction of this patient, 17%. After 10 days, ECMO removed. This is the removal of the ECMO. Sorry, the slides is not moving. One. Someone is taking control of it. Okay. Can you, thank you, leave it. Okay. So this is the removal, percutaneous removal. There was no issue on the ECMO side. So it was on Impella for 10 days, 4 more days on Impella, CRRT because patient developed progressive kidney failure and we couldn't stay off from the CRRT. Patient was discharged after 45 days, ejection fraction at discharge rise to 29%. Thank you.